Assessing nutrition in mental health nursing.
When we talk about mental health, we often jump straight to diagnoses and medications. But as nurses, one of our most powerful assessment tools is much more basic: nutrition. What and how someone eats directly affects mood, cognition, energy, and safety. If you miss nutrition, you may miss the root of the mental health concern. The brain uses about 20% of the body's total energy. Neurotransmitters don't appear out of nowhere. They are built from nutrients. When nutrition is inadequate, patients may present with symptoms that look psychiatric but are actually physiological. This is where nursing judgment matters. Protein provides the amino acids needed to build serotonin, dopamine, and norepinephrine. Carbohydrates support serotonin availability and stable energy. Healthy fats, especially omega-3s, support brain structure and mood regulation. When intake is poor, mood regulation suffers, and medications may appear ineffective even when they're prescribed correctly. Vitamin deficiencies often whisper instead of shout. Low B vitamins can look like depression, fatigue, or poor concentration. Vitamin D deficiency may contribute to low mood and seasonal depression. Vitamin C supports the body's stress response. Nurses are often the first to notice these subtle patterns during assessment. Mineral and electrolyte imbalances can dramatically affect mental status. Iron deficiency can cause fatigue and cognitive slowing. Low magnesium may contribute to anxiety and sleep disturbance. Sodium and potassium imbalances can cause confusion, agitation, and even psychosis-like symptoms. Electrolyte imbalance is not just medical. It directly affects behavior and safety. Dehydration is one of the most common and overlooked contributors to altered mental status. It can cause confusion, irritability, fatigue, and poor attention. Older adults and patients taking psychotropic medications are especially at risk. Assessing hydration is basic nursing and powerful psychiatric care. Nutrition assessment is not separate from mental health assessment. As psychiatric nurses, we assess appetite changes with depression, anxiety, and mania. We look for disordered eating patterns, barriers to eating, and medication-related weight or appetite changes. Substance use, especially alcohol, plays a major role in nutritional status. Appetite tells a story, even when patients don't say the words. Psychiatric medications and nutrition are deeply connected. Antipsychotics increase metabolic risk. Lithium requires careful attention to sodium and hydration. SSRIs can change appetite. Stimulants may suppress hunger. Alcohol destabilizes mood. Chronic alcohol use can cause malnutrition and deficiencies in folate, niacin, and thiamine, with thiamine deficiency being critical due to the risk of Wernicke-Korsakoff syndrome. Teaching patients how food and fluids interact with medications is essential nursing care. Nutritional teaching is not about perfection, it's about empowerment. Small, realistic changes can improve mood, energy, and medication effectiveness. Education builds trust, supports recovery, and reduces relapse risk. This is therapeutic teaching, not dietary policing. Psychiatric nursing is about pattern recognition. When you assess nutrition, you are often seeing early warning signs of deterioration or risk. Nutrition affects mood, cognition, and safety. Assessing nutrition is assessing mental health. This is how nurses protect patients, by noticing what others overlook. A nutritional assessment often reveals what the patient cannot yet put into words.